Okay, so welcome everyone. I'm really excited to be hosting this month's Net Chatter. Just a little bit about myself. My name is Jasmine Carroll and I'm the social media ambassador for Net Cancer Foundation. One of the reasons I joined Net Cancer Foundation was to help our growth strategy of fueling collaboration to find a cure for NETs. And unfortunately, my very close auntie did not survive her battle with NETs, but she fought very, very hard and gracefully and was still able to enjoy her life whilst living with NETs. These chatters are really important for all of us, so it's great to see all of you on this call today. So again, welcome our monthly Net Chatter. We have a special guest speaker, Alexandra Gangi, who will be introduced to you by Rachel in a few moments. Simon Robinson, who you may already know, our founder, he is in London, in a London hospital, having surgery for his own neck cancer. There he is, Simon, you can give us a wave. He hopes to be back with us for our next meeting to host it on June the 24th, when Eloisa Suarez is going to be our guest speaker. So just before I pass you over to Rachel, may I remind you that we record all of our speakers and shows and show their talks on our website, and our website is www.netcancerfoundation.com. So feel free to check out our most recent event, which was our research conference held early in the month, which had 5 guest speakers. Thank you for listening, and over to you, Rachel.
Thank you, Jasmine. I'm excited to see everyone here at this talk. It's good to see you all, and I'm extra excited to introduce our speaker for today, Dr. Alexandra Gangi. She is a surgical oncologist out in California at Cedars-Sinai. She has over 10 years of experience with neuroendocrine tumors, and she studies differences between primary and metastatic lesions. So I'm really excited to hear her talk today, as I'm sure you all are. And so, Alexandra, I'll pass it over to you.
Okay. Thank you so much, Rachel and everyone, and Simon, for inviting me to be part of this. I know we've been trying to get this done for some time, but with the time differences, it's been challenging. So good morning to people here on the West Coast. Good evening to you in the UK, and good afternoon on the East Coast. You guys see that?
Yes, looks great.
Looks like a net talk and not a busy desktop, I hope. Okay. So in trying to come up with the topic, given that there's a mix of providers and patients and caregivers and everything on here, I just figured we would talk a little bit about why patients with neuroendocrine tumors should see a surgeon and what the implications of surgery potentially are. So again, thank you all for allowing me to participate, and it's really a privilege to be here. As you all know, the incidence of neuroendocrine tumors is consistently increasing. This is a study that was done in 2017. You can see that the age-adjusted incidence of neuroendocrine tumors was 1 per 100,000 persons in the early 1970s, and that's increased to 6.9 per 100,000 by about the year 2012. And this could obviously be secondary to better diagnostic modalities, but likely is secondary to our familiarity with neuroendocrine tumors as a whole. Again, everyone in this audience certainly knows that the anatomic distribution of neuroendocrine tumors is pretty vast. You can have, primary bronchial, lung tumors, pancreatic tumors, small intestinal tumors, rectal, colon, and then there's all the others, the thyroid, adrenal, pheo, paraganglioma, cervix, and ovary. It just means that, we're not limited when we're seeing patients with neuroendocrine tumors. There's a lot of different things to think about. And frequently that's something that could lead to misdiagnosis. For those of you who are on the call and are patients or caregivers, this was a staggering statistic that was presented at World Neck Cancer Awareness Day a while ago, and it essentially showed that 1 in 2 patients were diagnosed with other conditions when they actually had a neuroendocrine cancer. So they were told things like, you have irritable bowel disease, or you have gastritis, so don't worry about it, it's just anxiety, or you have asthma, or it's menopause. But in reality, these patients had neuroendocrine tumors and were living with their symptoms for prolonged periods of time before anyone was able to give them an appropriate diagnosis. So what we talk about frequently with patients is, what should you expect after your initial diagnosis? And I think the most important thing that we all suggest is connecting with a neuroendocrine tumor specialist. And I think that's one of the reasons that Simon probably, initiated this group, to provide more information to patients and caregivers, get a group of, physicians and medical professionals who are interested in treating NETs, and really creating an environment in which you are able to connect with the specialist. You should then discuss your options and why specific options may be right or wrong for you. These options may include medical treatments such as hormone therapy, chemotherapy, immunotherapy, sometimes surgery, which Simon can probably talk to when he gets back and recovers quickly from his operation. And then other therapies like PRT, radiation therapy, and liver-directed therapies. As a physician, our responsibilities are essentially to provide patients with easily understandable information regarding your diagnosis, to provide a list of options, and provide the pros and cons of each option specifically and how it relates to you. And ultimately, our job is to work directly with you to create a plan, ultimately. It should not be a situation in which we're telling you what to do and you're kind of just accepting without understanding why it may be of tremendous benefit. As a patient, your responsibilities are to inform your physician of your symptoms, lifestyle, your goals, your treatment preferences, and your past experiences. So when I mention goals, some patients have, very specific goals. They may want to go hike Mount Kilimanjaro, and, that's not feasible if you're, getting some kind of systemic therapy for which you need to be available for some period of time, or you can't do X number of weeks of PRT. Others just want to feel better, need symptom relief, and maybe want to improve the number of times they're having to go to the restroom or they're flushing or things of that variety. And then past experiences is something that I found really important. Almost everyone we know has had a friend, a family member, or someone who's been affected by cancer, and sometimes they've seen fairly horrific processes or treatments that did not go well, or some period of time that was really difficult to manage. And so sometimes when you have these past experiences, they lead you to believe that you're going to follow that same path. Frequently just sharing that with your physician and allowing us to give you more information in terms of what your journey may look like is sometimes very helpful. And I think most importantly, what I stress to my patients is be open-minded about exploring different treatment options, because there's so many of them for a variety of neuroendocrine tumors. And so it's important really to learn what might be best suited for you at a particular time point. Now, what if you need surgery? How do you choose your surgeon? There's a number of phenomenal surgeons across the world who are dedicated to their craft and do an excellent job. But in the setting of neuroendocrine tumors, you really want to find a specialist, just because there's so many nuances in terms of how to manage tumors, both primary and metastatic, and timing of surgery and how it may benefit you. So one way to find that is through using a variety of patient support groups, getting recommendations that way. In seeing your surgeon, you may want to ask if they've seen or done this before, if they've treated other patients with neuroendocrine tumors and what their level of experience is. Typically, you'd want to ask your surgeon if they participate in a tumor board or work with other neuroendocrine tumor specialists routinely. One of the most important components is that you really trust your surgeon and you feel empowered to add your own perspective. So if I'm saying something that makes absolutely no sense to you, you should feel comfortable enough to tell me that it doesn't make sense, or you don't understand why, or you disagree, or any of those things. It's important to have that type of relationship. And don't be afraid to seek another opinion. We have patients frequently who come to us for second or third opinions and ultimately may return to their initial surgeon or treatment team, and that's not an issue that doesn't hurt anyone's ego. And I think, especially in the neuroendocrine community, we all really enjoy working together to provide the best care for our patients ultimately. And what if you need surgery? Well, there's a number of factors that go into deciding which patients may benefit from surgery, and I'm going to try to touch on most of them throughout this, the next 40 minutes or so. The reality is we determine if surgery is necessary or could be potentially beneficial based on your tumor type, so the location of origin and the specific pathologic features, things like mitoses, Ki-67 index, differentiation, the extent of disease, whether you have metastatic disease. Does that mean that you have regional disease, meaning you have involved lymph nodes and things immediately surrounding your tumor, or distant disease? Do you have metastases in other places like the bone or the lung or the brain? And then also symptoms. Are you being seen by a surgical specialist because you have specific symptoms related to your tumor, or are you just being seen by a surgeon because they found a tumor and they think you should get it out? And then other factors always come into play. What is the overall health of the patient? Are you a candidate for surgery? Frequently, we need to put you under general anesthesia. Sometimes these events can be stressful to the rest of the body. They could be stressful to your heart. We sometimes see patients who have carcinoid heart disease, severe enough that it may preclude them from having a highly invasive operation. And so at least at our center, we have a very robust cardiac program. A lot of our patients who have carcinoid heart disease will frequently undergo valve replacement and management of their cardiac issues, and then will be deemed eligible for surgery if that was the initial plan at outset. But these are all considerations that need to be taken into account when deciding what the next steps are. So I've touched briefly on the concept of functional and non-functional tumors. Essentially, functional tumors are defined as you having symptoms of hormone excess from your tumor. So something we all know about is carcinoid syndrome, where you produce hormones like serotonin. It can cause flushing, diarrhea, bronchospasm, valvular heart disease, anxiety, etc. And then there are also a subset of pancreatic neuroendocrine tumors that are considered functional because they release specific subtypes of hormone depending from the cell type from which they arise. So insulinomas, gastrinomas, glucagonomas, and they all have a constellation of symptoms that are related by hormone excess secreted there. So I just wanted to, that's a small nuance that's important in determining what to do. And then non-functional is what I am before I've had my morning cup of coffee, but it's also in the setting of neuroendocrine tumors, patients who are asymptomatic, or they do not have symptoms necessarily related to hormone excess from their neuroendocrine tumor. They may have, abdominal pain secondary to an obstructive process, but the tumor itself is non-functional and not overproducing any type of hormone. So first I'm going to touch on pancreatic neuroendocrine tumors and when to take them out. Well, if they're functional, meaning if they're producing a hormone like the ones we just discussed, insulin, glucagon, they should come out. Tumors larger than 2 centimeters should come out. Less than 1 centimeter can stay, and 1 to 2 centimeters, there's some controversy, and I'll touch on that in a second. And then patients who have isolated, meaning non-metastatic, high-grade tumors, they're also eligible for surgical intervention and resection. So what about this concept of what to do with tumors that are between 1 to 2 centimeters? Well, there's a few studies. Most are retrospective in nature. We don't have a ton of surgical prospective studies in neuroendocrine tumors, partially because they would just require such long follow-up that it's frequently difficult to do that. And secondary, just because we don't have necessarily enough information to be able to safely suggest that we do or don't do specific things. The first study that I mentioned on this slide actually is associated with the image, the graphic that you see. And in this study, essentially 128 patients were evaluated. And what they found that patients who had tumors less than 1 centimeter, none of them had, node positive or metastatic disease. Now, again, this is a small number of patients, but it's really the best type of data that we have available to us. And then once your tumor was over 1 centimeter, you started to have, there was one patient who had node positive disease and one patient who had distant metastatic disease out of 17, which isn't terribly high. But you can see that as the tumor size increases past 2, the likelihood of having node positive disease or metastatic disease increases, and therefore, again, supporting the idea that tumors greater than 2 centimeters should be removed, and we have a little bit of wiggle room for the 1 to 2, and that we can observe the less than 1 centimeter tumors. A second study that looked at a higher number of patients, all who had tumors smaller than 2 centimeters, and divided patients essentially in increments of half a centimeter in looking at their outcomes, found that out of 392 patients, the rates of node positive disease were higher for patients who had 1.5 to 2 centimeter lesions as compared to 1 to 1.5 centimeter lesions. So essentially a doubling of the rate, but still well under 20% for both. And then in the last study, essentially 110 patients were evaluated. And again, you can see that 18% of patients with 1 to 2 centimeter tumors had node positive disease, whereas 53% of patients with tumors 2 to 2.9 centimeters in size had node positive disease. So based on information like this, again, retrospective, the current guidelines of multiple neuroendocrine tumor societies recommend observation for asymptomatic, non-functioning pancreatic neuroendocrine tumors under a centimeter in size, and resection for appropriate surgical candidates with PNETs greater than 2 centimeters in size. This is regardless of functional or non. And then essentially an individualized decision for resection versus observations for those patients who have pancreatic neuroendocrine tumors between 1 and 2 centimeters. And this is based on patient age, comorbidities, tumor location, and other radiographic characteristics, which I'll touch upon briefly. What about patients who have metastatic disease? So in patients who have metastatic disease, you can consider cytoreductive surgery in appropriately selected cases. And cytoreductive surgery essentially means an operation to remove both the primary tumor and additional metastatic sites of disease. The reason I say can consider, because again, no two patients are alike. So you may have a person who presents with a pancreatic neuroendocrine tumor who would require a concomitant liver resection because they only have liver, solitary metastasis or minimal number of metastases in the liver, amenable to removal, and that would be a favorable candidate for potential resection. But you may also have a patient who has a pancreatic neuroendocrine tumor who has liver disease and peritoneal disease and other, potential distant disease or nodal disease in whom surgery may not necessarily be of tremendous benefit. So there's no definite yes or no answer, and a lot of it just depends on presentation, symptoms, potential responses to therapy, and things of that variety. Typically, in patients with metastatic disease, we do have some systemic agents that work quite well in patients to reduce tumor burden and sometimes provide long-term benefits. So typically in these patients, we would favor a neoadjuvant approach with some preoperative systemic treatment to assess disease response. It also gives us an idea of, does your tumor actually respond to the particular treatment that we're giving you, which is much easier to assess when you actually have disease there to evaluate as compared to, doing it post-operatively or post-surgically. So why do I mention surgery type? Well, with the pancreas, really it all comes down to real estate. So we may present you with an option of an enucleation, which I'll explain, or a resection. So if you're told you need a resection, frequently you'll be told you need a distal pancreatectomy, or something known as a Whipple procedure, a pancreaticoduodenectomy. And if you're told you need an enucleation, that essentially means if you can see this mass here. It's an ugly, I don't know what color that is, but you can see that it's really sitting on the periphery of the pancreas. And we think that we could just remove this safely without injuring the underlying pancreatic parenchyma. What you can't see here is there's an important duct that's running right through the middle of the pancreas. And it's typically a little bit lower than it is high. But injury to that duct can be fairly catastrophic to the patient, not necessarily, catastrophic in the sense that, imminent death is possible, but just prolonged leakage and drains and things of that variety that could be an emotional strain for a patient who's having to deal with a lot of that. So when we're considering an enucleation, we want to make sure that the tumor is small enough and far away enough from a duct where we could actually safely just cut that lesion out. And typically we would do this for tumors that are smaller than 2 centimeters for the same reason that I discussed, because if they're bigger than 2 centimeters, we're concerned that you may have nodal disease, and so we would do a more formal type of resection in that patient population. So again, if you have a tumor that's in the distal pancreas, and this one is very central in the distal pancreas, well, to remove this, we would need to remove the whole distal half, or the left-sided half, essentially, of the pancreas, and so that would be a distal pancreatectomy. The Whipple comes into play if you have a tumor here in the head of the pancreas. The vascular anatomy to this part of the body is such that the blood flow to the head of the pancreas provides blood simultaneously to the duodenum, which is the first portion of the small intestine. And so to remove this tumor that's fairly central, essentially this entire segment demonstrated by this dotted line, would need to come out. There's some very important vessels here known as the superior mesenteric vein and artery, and they essentially divide the head and tail of the pancreas, and are frequently our surgical landmarks. But once you remove the head of the pancreas, it then requires a much more complex reconstruction than does a distal pancreatectomy, because you could see if we have to remove this whole part of the pancreas, then we end up having to remove kind of everything along the dotted lines, part of the small intestine, the duodenum. We have to transect the bile duct, which allows for bile to flow from the liver into the small intestine to break down food, and then it requires a fairly complex reconstruction. So why is this important? Because if you're seeing a patient with a 1.1 centimeter neuroendocrine tumor that's non-functional in the head of the pancreas that may require a Whipple operation, you may say, let's trial a period of observation, because if this thing doesn't grow, then the likelihood of anything really bad happening is low. However, that same patient may present to you with a tumor in the distal tip of the pancreas, where surgery really would not be that challenging, would not require a complex reconstruction, can probably be done minimally invasively. And in that very same patient, you might say, okay, well, based on the location, it would make sense to just get this out as compared to proceeding with observation. So decisions are made based on some of this information. What about small bowel neuroendocrine tumors? One of my particular favorite topics. So the small bowel is the most common site in the GI tract where neuroendocrine tumors can present. There's an incidence of about 10 to 12 million, 10 to 12 per million, not 10 to 12 million. If that was the case, we wouldn't be having all of these small groups, because it would be a true health emergency. And then 35 to 40% of small bowel neuroendocrine tumors are actually multicentric or multifocal. Now, typically, small bowel neuroendocrine tumors tend to be well differentiated, which in some ways is a plus. They're slow growing, but the challenge there is that patients will frequently not present with symptoms until they're fairly advanced. Because they grow so slowly and don't cause any problems, a lot of times there has to be a lot of growth for a patient to actually feel something. And typically they're not easy to pick up on imaging necessarily. This is a patient with a primary small bowel neuroendocrine tumor that was incidentally picked up on a scan, and this is not a common thing, but you could see essentially the darker gray is the rest of the bowel, and then you see this brighter white spot, and that's an endoluminal mass in the small intestine. Frequently what we'll see is we won't really see the primary, but we may see a big node or something in the liver or other locations that would lead us to believe that there's a tumor there, and then further workup will frequently determine that this is a small bowel tumor. So why consider resecting a small intestinal neuroendocrine tumor? Well, it could be curative for patients who have disease in the small intestine only, and potentially in the small intestine and lymph nodes. It may prevent future metastases, both local, meaning to the lymph nodes, or distant, such as the liver. It can prevent or alleviate bleeding or obstruction, although fairly uncommon. Some patients do develop bleeding secondary to progressive growth of these tumors. And obstruction is more common, so a lot of our patients will actually present with blockage, because this is basically a blockage within a pipe. And ultimately, sometimes this can cause twisting, intermittent pain, things of that variety that'll lead to you feeling not well. It can reduce circulating hormone levels, and ultimately it may improve survival. This is primarily in retrospective studies, and I'll talk about that in a minute or so. But the surgical approach for management of neuroendocrine tumors really depends on the extent of disease and the location of the tumor. So currently, with minimally invasive approaches being more attractive to patients and some physicians, patients will frequently ask, can you do this laparoscopically or robotically? And my answer is, well, we always start that way. But really, the standard of care for small bowel neuroendocrine tumors is to actually manually palpate the small intestine. So you can do this all through a very, very small incision. But the reason for that is because, if you remember, I told you about 35 to 40% of these tumors are multifocal, meaning there's more than one. And sometimes they're millimeters in size. When we're using the robot, we as surgeons have absolutely no haptic feedback, so we can't feel anything that we're touching. And when we're using minimally invasive tools, we're basically using long instruments that will allow you to feel, you know, firmness or some of the density of the tissue that you're holding. But again, for something that's a few millimeters in size, it's virtually impossible to be able to adequately assess if there's something there. So again, I think it's important to note that, you know, if you're being told that everything can be done through, you know, tiny 5 millimeter incisions, this is something that you should be aware of, because the whole goal is, if you go to surgery, we want to get everything out so that you don't have to go back. So the standard of care is essentially to remove the piece of, or the segment of intestine that has tumor within it. That may be one tumor or multiple, and then to remove the associated nodal disease, and I'll touch on that on the next slide. What about removing the gallbladder or a cholecystectomy? Well, frequently, you know, patients that I see have metastatic disease. And so in that setting, patients are going on therapy, sometimes with somatostatin analog therapy, which we know can sometimes cause cholecystitis ultimately. And so if we're going in to do some kind of a resection, we'll frequently discuss the possibility of removing the gallbladder at the same time, so that we don't have to come back for another operation should cholecystitis arise. It can eliminate the problem of gallstones, et cetera, et cetera. If a patient, if we think it's just a primary tumor that we're removing, and I don't have, you know, any preconceived notion that the patient will ultimately be on somatostatin analog therapy, then we can frequently avoid the cholecystectomy, but that's another question that commonly comes up. So I keep talking about lymph nodes. And here on these graphics, you can see essentially this is what it does not look like when we go in there. But this is an appropriate anatomic representation. Essentially, you have these main vessels, and you have all of these feeding vessels that are supplying portions of the intestine. And right along where the feeding vessels are, you also have all of these lymphatic channels and lymph nodes. So if you have a primary tumor, like depicted in this photo on the top, right here, then the drainage from the bowel goes through these little vessels, and then the lymph nodes in that segment of mesentery may be the ones that first absorb some of the tumor, and so those would be the affected lymph nodes. So the goal of the operation would be to remove that tumor with a negative margin, which if I wanted to do that, I can cut right here. But then if I take all of this intestine to get, or I'm sorry, all of this mesentery to get those affected lymph nodes, you're not going to get any blood flow back to the intestine. So essentially, you have to cut out a wedge of tumor. Now, frequently what happens, and what I see commonly, is patients will present with fairly advanced disease, and because all of these small feeding vessels ultimately feed back to this important vessel, again known as the superior mesenteric artery, which you could see is under this transected pancreas. We talked about that a second ago. We'll see large tumors that are sitting like right at what's called the root of the mesentery. That's something that you may have heard. Now, tumors that are at the root of the mesentery are much more challenging than something peripheral or on the edge, like these lymph nodes depicted in this picture, only because this main vessel, we can't get rid of it. We don't want to cut off that blood supply, because it would ultimately cut off the blood supply to all of your small intestine, and that's just not a favorable outcome for patients. So sometimes you're able to, you know, peel that area of disease off, et cetera, et cetera. But frequently, to get that nodal disease, you go as high as you need, and then resect the small bowel with the associated mesentery. What about management of small bowel neuroendocrine tumors if patients are metastatic? This is an area of tremendous interest to me, again, primarily because I see a lot of patients with fairly advanced disease. And frequently these patients will have been diagnosed with a metastatic small bowel neuroendocrine tumor, and because they were metastatic at the time of diagnosis, no one removed their small bowel tumor, which can cause problems down the line. So if patients are symptomatic, and I'm not talking about functional or hormone symptomatic, I'm talking about, you know, I have abdominal pain, I have nausea, vomiting, you know, I can't eat, food fear, things of that variety. It makes sense. You take out the primary tumor because it's clearly affecting quality of life. What about patients who are asymptomatic? Well, that's an area of tremendous controversy, and it really depends on who you speak to. So the ENETS and NANETS guidelines acknowledge that there's a lack of prospective evidence that essentially doesn't permit for definite conclusions on any potential survival benefit. But I mentioned earlier that prospective data is fairly difficult to obtain, primarily because follow-up durations would be so long. and it would require randomization. So we'd have to tell some patients, well, you have no symptoms. I'm going to operate on you, but we're not going to operate on you. We're going to operate on you, but we're not going to operate on you. And that's could be difficult for patients to agree to. They may say, well, you know, I definitely don't want the operation and I want to be in that group, or I really want an operation, I want to be in this group. So it's the question of equipoise and how do we obtain data that would potentially answer this question. And of course, we have to consider the risks and benefits of surgery because it's a procedure and it could have consequences. And if you're really asymptomatic, meaning if you're feeling perfectly well with metastatic disease and your primary tumor in place, how am I going to help you if I take out your primary tumor? I think the challenge there is sometimes our ability to ask patients what symptoms they may be having, which is another reason why it's important to see a neuroendocrine tumor specialist. You may have really vague GI discomfort that you've been dealing with for 20 years because it took you 10 years to get diagnosed, and then for the last 10 years you're just used to having vague GI discomfort, or not having normal bowel movements, or having completely changed your diet and being very, very thin. Those are symptoms, but you may not think of them necessarily as symptoms, so it requires that we ask the appropriate questions. And why, if removal of the primary tumor, if it did improve survival, why would it do so? Well, like we talked about, it could prevent obstruction, bleeding, bowel ischemia, meaning lack of blood flow to the intestine based on the location of those tumors. Remember on that last graphic, we saw how some of the nodal disease can sit right on the blood vessel and prevent adequate blood flow from getting to parts of the intestine. It can prevent perforation, or essentially a hole being made in the intestine, or progression of disease. This would then allow for fewer patients to need emergency surgery for the above. We do have data, again, retrospective, that patients with neuroendocrine tumors who undergo emergency surgery frequently have suboptimal resection, partially because they're probably sick at the time, secondarily because they're probably not being managed by a neuroendocrine tumor specialist, and so sometimes residual disease is left behind, the lymph nodes are not resected, and yet we were just in your abdomen, to try to alleviate the problem. So sometimes it could prevent you from having to undergo a reoperation or just having a suboptimal one. We think that if we leave the tumor in place, well, it's going to continue to grow, and that could lead to further peritoneal spread. T4 disease is not stage 4. T essentially means the depth of the tumor within the intestine. So it grows from the inside out, and eventually if it keeps growing and goes all the way through the wall, then tumor can disseminate outside of the intestine within the abdominal cavity. And then we postulate that if your primary tumor and nodes are potentially left in place, they may have the ability to continue to metastasize because they're there. So really nothing's stopping them. But I think the important questions that we need to answer, if we were to remove the primary tumor in patients who have metastatic disease that's not removable, what is the risk reduction for obstruction, bleeding, mesenteric fibrosis, and is overall survival really dictated by primary disease, or is it dictated by distant disease? And we think that it's primarily dictated by distant disease, but there may be some component for primary disease to allow for improved survival. Now, primary tumor resection in patients who are symptomatic. So this was a study that was done in 1996. And essentially they looked at 121 patients with midgut carcinoids. Almost all patients had metastatic disease and not resectable metastatic disease. So all of these patients underwent primary tumor resection, and 82% of the 93% of patients, 82% of the patients had partial or complete alleviation of symptoms, despite the fact that they had nodal disease, liver disease, and carcinomatosis. So that's a fairly staggering, rate of improvement for patients who had just one component of their overall tumor burden removed. And I think the take-home point of this was that, most patients actually do have symptoms and benefit from early aggressive surgery. And here you can see, nausea, distension, and abdominal pain, they were considered to be symptoms. And those are questions that we sometimes don't ask our patients. And you can see, again, there was tremendous improvement for those patients who did not have carcinoid syndrome who had resection. So given my interest in this topic, we're working on identifying how to best to study this further. But again, this is all retrospective data looking at small numbers of patients and some large national databases with large numbers of patients who had primary tumor resection or small bowel tumor resection in the setting of unresectable metastatic disease. And I'm not going to belabor you by going through every study, but you could see that the rates of overall survival, which may not be the perfect outcome measure that we should be looking at, but the rates of overall survival were better in all patients who had surgery. Now, you have to take this data with a grain of salt because we may be selecting patients who are overall healthier to have surgery. And so there is likely some inherent bias. It's not, none of these are perfect, but certainly worth further thought and exploration. And what if you have metastatic disease? Well, many patients do. This was a study that was published in 2008. And it was essentially data analysis from 28,000 cases of neuroendocrine tumor. And 50% of patients at the time of presentation had metastatic disease. 27% had distant metastases to the liver, lung, bone, etc. And about half of those patients had regional spread, meaning associated lymph nodes, etc., things of that variety. And so how do we manage liver metastases? Just to switch topics a little bit, and this is now my favorite topic. Well, there's a variety of ways, and I've essentially shown you imaging for 3 different patients that we may see. So, the first one on top has some isolated metastases that are fairly peripheral in the liver, and I know I'm only showing you one view, but you'll have to believe me that this was all there was. And these are, resectable. They can also be treated with, systemic therapies, targeted therapy, liver-directed therapy, and PRT. But this may be a person whom, when we discuss in tumor board, we can talk about, liver cytoreductive surgery as being a beneficial component of their treatment. This patient in the middle has, quite a bit more disease, both lobes, certainly still treatable, but we would be a little bit more hesitant to offer surgery just because usually there's more than meets the eye on the scan itself. And so sometimes there's other therapies that we could provide that would be better suited for this patient. And then this last patient is a patient who has even more disease than the one in the middle. This is not someone that we would favor surgery for, and some of the liver-directed therapies may be more challenging just because there's so much, there's almost more tumor than there is liver, and so that could be a challenge. But this is someone in whom chemotherapy, PRT and things of that variety may be of benefit. And I have liver transplant here with a star. So at our institution, I mean, we do consider patients with neuroendocrine tumors for liver transplant, but the standard guidelines for transplantation in terms of patients who may be eligible for liver transplant are similar to those same patients that may actually benefit from debulking. So typically you're supposed to have less than 50% disease involvement, no extrahepatic disease, meaning all of your metastatic disease has to be in the liver only, and your primary tumor has to have been removed. There has to be a duration of time from which you've had no progression of disease, a minimum of 6 months. Which is how long it would take anyways if you were on a transplant list. But those are frequently patients that we could manage with the other therapies we have available, and with a scarcity of organs may not be favorable. So at our institution, what we favor doing is patients who may look like this, who have basically exhausted all of their treatments, but really have had no progression for a significant duration of time. Meaning there's been no tumor growth, no new tumor, nothing of that variety, and they're still having symptoms and essentially have exhausted all options. We may consider someone like that for a transplant. But again, disease biology being what it is, we have to prove that our therapy would actually be helpful to the patient. And even post-transplant, we do think that ultimately those patients will develop additional metastases in the liver. So it's an option, but it's a start option. So when neuroendocrine tumors are present in the liver, how do we kind of manage those patients? Well, the first question is disease localized to one organ, meaning is it in the liver and nowhere else? Yes, limited liver disease, typically we will consider surgery, liver-directed therapies, PRT, and then systemic therapy. So that would be that first image that I showed you. What about if there's heavy tumor burden in the liver? Again, surgery may be an option depending on, is it all located in one side of the liver versus the other? Liver-directed therapy, if it's, whether it's that or if it's more diffuse, PRT, systemic therapy. Is there a heavy widespread tumor burden, including the liver? Well, in that case, surgery becomes a little bit more of a question. And we typically would favor some type of systemic therapy, again, based on the primary tumor type. Is it pancreatic? Is it small bowel? Is it lung? PRT, and then liver-directed therapies or catheter-directed therapies. So you could see that at any different point in your treatment, you may be someone who was here and had widespread tumor burden, and by doing systemic therapy, we've alleviated all of the other disease, and now all we're dealing with is limited liver disease, in which case you may all of a sudden jump from being in this category to this category. So at every time point of your treatment, it's important to kind of reassess. Just because something is not possible at one particular point does not mean that it's not an option in the future. When do we consider surgery? Basically when we can resect all of the disease, or at least 70% of the disease in the liver, and I'll talk about the studies that have been kind of instrumental in giving us that guidance. Patients who have grade 1 or grade 2 neuroendocrine tumors, so if you have a neuroendocrine carcinoma or a grade 3, that tends to be a little bit more aggressive, and this grade 1, grade 2 does not, high grade neuroendocrine carcinoma does not apply to the 70% cytoreduction rule. That's a slightly different treatment algorithm. Similar to every other surgery that we've discussed, the patient has to be a healthy surgical candidate with a healthy liver, meaning if you've had previous liver-directed therapies, previous chemotherapy, if you have an underlying liver disorder, things of that variety, that may alter your candidacy for different liver-specific treatments, surgery, liver-directed therapy, et cetera, that would be possible for you. And then sometimes we have patients who have, another area of interest of research of mine is the heterogeneity of tumors, as Rachel alluded to. So sometimes you start with a well-differentiated low-grade tumor that initiated in the small bowel, you had one liver met, and then now you have, 5 or 6, and one of those tumors, every single one is behaving well, but one of them keeps growing. You may get a biopsy and notice that the Ki-67 index on that is significantly higher, the mitotic rate is significantly higher. So it's essentially changed a little bit. It's heterogeneous from what your primary tumor type was. And what if that specific tumor is progressing only? Well, sometimes we may consider surgery, if feasible, to remove that, or liver-directed therapy specific to that tumor. But that's another area of further interest and further study that is required. So I mentioned that study to look at the 70% debulking. Essentially, in looking at 188 hepatic cytoreductions, 128 patients had small bowel neuroendocrine tumors of those 188. And essentially, the study looked at greater than 90% debulking of tumor, 70 to 90% debulking of tumor, and less than 70% debulking of tumor. And when looking at overall survival, the greater than 90% and the 70 to 90% debulking up here, there was no significant difference. These patients did really well. And so originally the thought was you have to get rid of all the tumor in the liver, otherwise it's not beneficial. Then that dropped down to a 90% debulking rule, and then this one essentially showed that even a 70% debulking is beneficial to these patients. Now, if you're only able to debulk less than 70%, we don't generally advocate for that. This is where that select patient who has progression of a solid MET or something of that variety may fit in. But ideally, if you're going to go in there to remove that solitary MET, you would also want to try to debulk as much of the disease as you can. What about progression-free survival? Again, 70% to 90% did better than less than 70% debulk, but there was a little bit of benefit for the greater than 90% debulking. I think the reality in the progression-free survival number is that, when I see patients with neuroendocrine tumor liver metastases, what I tell them is they have a 40% chance of recurrence within the next few years, especially if they have bilobar disease or fairly significant disease. So I've removed as many as 50, 60 tumors from one particular patient because we've been in there to do something else and to get rid of greater than 90% of the tumor. But the reality is that at the time of the operation, both myself and the patient know that there's a high risk of recurrence. So I think that's the reality when considering progression-free survival. This next slide doesn't show anything, but I think ultimately what I was trying to show with PRT, we also think that there may be a role for patients who have tumors that are greater than 3 centimeters in size, because a study from Strasbourg essentially showed that patients who had, and a large lesion was defined as greater than 3 centimeters, as I just mentioned, but patients who had no large lesions did better with the PRT plus octreotide versus patients who had a large lesion. So consideration of potential, debulking or shrinkage somehow through liver-directed means of the larger tumor may be of benefit. And then, so again, this is the patients who had no large lesions versus patients who had a large lesion. Both had great response, but this solid line is obviously better. And then this graphic essentially shows that the baseline liver lesion size, if it was basically 2 centimeters or less, 2 to 4 centimeters or greater than 4 centimeters, patients who had smaller tumors had much more impressive shrinkage of their liver tumor when having PRT as compared to those patients who had large tumors, as demonstrated, essentially by the purple. So even with these, new systemic treatments that are showing tremendous promise, there may still be some benefit in cytoreductive surgery. What about, our surgical approach, kind of like we talked about in the pancreas? This is, again, not what the liver looks like when we go into your abdomen, but the liver is divided into 8 segments. Essentially, there is a blood supply from the portal vein independently to each of the segments, and drainage through the hepatic veins. And then there's obviously an artery as well that supplies about 30% of the blood flow, and the biliary system. So when deciding a type of surgery, for example, this person in panel A has this tumor in the left lateral sector. There's 2 ways to address this. One is essentially doing a formal anatomic resection, meaning we would take all of the little blood, the blood supply specifically to that segment of the liver, transect the bile ducts, taking bile back from that segment of the liver, and cut out this whole portion in pink, versus just being able to do a wedge resection and preserving much of the other healthy liver, and not necessarily removing this whole segment. Typically for a tumor like this, for a neuroendocrine liver metastasis like this, most of us would favor a wedge resection, and for most neuroendocrine liver metastases, we favor a wedge resection because they typically actually push. They don't really penetrate and invade the surrounding parenchyma of the liver, which is a little bit different from things like colorectal cancers or hepatocellular cancers. Those grow into the surrounding parenchyma. Neuroendocrine tumors just kind of find their spot and push away. So this is much more feasible. For something like this that's more central, sitting on this main vein, well, sometimes you can't take that main vein, and this may not necessarily be feasible because of changing blood flow, et cetera, et cetera. It all depends. You have to think of this as ultimately a 3D organ, and so just by showing the dot where we think the tumor is, it's not a perfect comparison, but should give you some idea. So ultimately, you could see, based on tumor location, there's a bunch of different ways that we may want to resect the tumors. I would say panel E is most typically what we see with our neuroendocrine liver tumor patients. They have, a few significant points of disease in different parts of the liver. So sometimes that requires a combined anatomic resection approach and wedge, versus just doing, multiple wedge resections and an ablation. I'm going to show you an actual graphic image. So if that's going to bother you, please close your eyes for a second. But this is a patient in whom we removed multiple neuroendocrine liver tumors recently. So these are some of the tumors, and there's plenty more. But you could see that we were able to do wedge resections in multiple different segments of the liver and leave all of the healthy liver parenchyma. The patient did very well and had 100% debulking surgery. So this is a favorable outcome. We have different approaches. We have minimally invasive approaches. We can do this. Sometimes we could, that last case was open, so bigger incision. This is a patient in whom we're removing a neuroendocrine liver tumor with the robot. So I'm over here on the robot, and this is my team. This is what we're seeing on the screen. So that little wedge of tumor comes out. And then sometimes we consider something known as ablation, and that essentially involves here you can see what we're seeing. So we have a camera inside looking at the abdomen. This black thing is an ultrasound, and then this is basically a needle that goes in, and this is kind of the cartoon graphic that you can see here. So we're able to see where the tumor is in the liver. Again, 3D structure, it's pretty deep. And then using the ultrasound as a guide, we're able to put a probe directly into the tumor and essentially apply some microwavable heat to basically kill that tumor. And that could frequently be done minimally invasively. Sometimes we need to do it in the OR based on tumor location. Other times it's done in the interventional radiology or imaging suite. So again, another option. So why should we do surgery for neuroendocrine liver mets? Well, again, it may provide potential for cure. It may provide a potential survival advantage over no surgery, and it resets the clock potentially. The surgical debulking concept, which we talked about, shows that reduction of 70% of the tumor burden improves both progression-free and overall survival. And really, there's decreased complications with newer techniques that we have available. So with all the tissue sparing and parenchymal sparing surgery and ablation versus resection, we're not taking out huge segments of liver, which is what we used to do historically. We're able to just take out the diseased segments, and patients do pretty well post-operatively. One quick comment about liver-directed approaches. So, just basic information. The liver has a dual blood supply. Most of the blood supply is provided by the portal vein, and about 30% is provided by the hepatic artery, essentially this red thing here. Liver tumors, interestingly, obtain most of their blood supply from the hepatic artery, whereas the healthy liver receives most of its blood supply from the portal vein. So liver-directed approaches or catheter-directed therapy allows treatment to those tumors while sparing healthy liver tissue. So essentially, you may have heard of things like bland embolization or chemoembolization or Y90 or TARE, things of that variety. And what happens there is our interventional radiologists are able to place, a catheter within the hepatic artery segment that's feeding those individual tumors, like you can see here, and then doing any variety of these treatments to kill these tumors directly. So definitely another adjunctive treatment that's very beneficial to our patients and can be combined with all of the different therapy modalities that we've discussed. What about life after surgery? Again, it depends on what type of surgery you're having, which organs are involved, what's the duration of the procedure, how much disease do you have, and that would kind of dictate what your post-operative course is like. And your recovery ultimately depends on your overall health and all of the above things I've mentioned. So one thing I advocate highly for in my patients is to get healthy before surgery and do as much prehabilitation as you can, walking, stationary, biking, eating healthy, and essentially leaving all the stress to me. But I think that's of tremendous benefits to patients, and they do really well. What should you expect after your procedure? Well, it depends again on what you're having done, but you're going to have some pain. It varies based on your operation and your tolerance. And the job of your team is to manage your pain. We don't expect you to have zero pain, but we don't want you to have 10 out of 10 pain. So we'll treat that with medications and things of that variety. The thing that always shocks my patients is when I say, yeah, you're going to walk the same day or the day after your surgery. They're like, but what do you mean? I just had surgery. And I'm like, well, yeah, okay. But you have pain meds on board, and it's the thing that's going to help you get better faster. So you're not bed bound. If you are, we will specifically tell you that you can't get up. But other than that, we expect you to get up and moving. We will typically start you on a diet. I say eventually because I do a lot of bowel work. And so sometimes, it takes a couple days before we let you eat or drink again, just because we want everything to wake up and heal well. But if you're having lung surgery, you're usually on a regular diet that afternoon. How long you stay in the hospital is based on all of the above. And typically you'll see us 1 to 2 weeks after discharge. After that, you should have routine follow-ups with appropriate members of your treatment team to monitor your progress, monitor your neuroendocrine tumor, discuss need for options and additional treatments. And between visits, not that you should wait until a visit to ask us questions, but if questions come up, keep a log of questions that you may have. Keep a log of symptoms that you're experiencing, because that's really helpful to us in trying to determine exactly what's happening and how we can help you. And if something doesn't feel right, please don't wait. Like I said, if we're not seeing you for another 2 weeks, don't sit at home struggling in the dark. Please call us. We definitely want to hear from you. And you can even tell us that you're doing well if you'd like. That's always a welcomed information. And lastly, thank you again so much to the Net Cancer Foundation for asking me to speak to you today, and essentially to all the other neuroendocrine support groups and foundations that are available. I think I love working with this group of physicians and patients, and it's really, really a privilege. So thank you.
Thank you very much, Alexandra. I don't know if we have time for some questions, but there were a couple of questions in the chat.
Yeah, I think we have time for a couple questions. I can read the first one that I see in the chat. Simon AM has mentioned, as you mentioned, biomarkers for treatment, especially chemotherapy and neuroendocrine neoplasm, unfortunately, are relatively few. For you as a surgical oncologist, what is the time frame that you need to build up your decision if surgery or treatment or a combination thereof is applicable? And if at all, in what cases do you consider rebiopsy of, for example, liver mets?
Sure. So in terms of decision making for surgery and treatment, I think it depends on exactly why we're seeing the patient. Again, if someone's symptomatic, it doesn't take me a very long time to decide that we need to do something more urgently. If it's something that we've been watching for years and there's not tremendous change, especially in the time of COVID, for example, it was an unprecedented time where surgery really had to take a back seat. But it depends on everything else that's going on in life. So, if I think you need surgery and within the next 3 months and you tell me, well, my son's getting married in 3 months and I really want to do it after, then that's a consideration. So it's a group decision, but it depends on what we're even considering surgery for. If something is progressing quickly, then obviously we would want to do it faster. If something's stable, no. What cases do I consider rebiopsy of liver mets? If we see a sudden change, if something is rapidly progressing where it wasn't previously, sometimes it's helpful to obtain a repeat biopsy.
Absolutely. So there are 2 more questions in the chat. We're about a minute over though. So I would encourage, to reach out to Dr. Alexandra, personally, and I think that she'll be able to answer those questions. So with that being said, thank you. That was an excellent talk. Jasmine or Kate, is there anything you'd like to say before we close?
No, I think I just wanted to reiterate a great talk, thanks. And it's great to see everyone here, and hello, because I haven't said anything yet. Just another reminder that we have another Net Chatter in a month's time, so 24th of June, where Heloisa Soares is the guest speaker. So hopefully everyone can make it along to that, and it would be great to see everyone.
All right, well, thank you again, Alexandra, for their talk, and thank you all for attending. And with that, I will see everyone in a month.
Great, thank you guys.
Thank you, everyone.